dear attendees, dear colleagues, dear IAS fellows, my name is Alexander Peikert from the Medical University of Graz, and it is my distinct pleasure to welcome all of you to the fourth part of the Inflammation Academy webinar series. The topic of today's webinar is inflammatory biomarkers in cardiovascular disease from hs-CRP to IL-6 and beyond. So in the beginning, I want to briefly introduce to today's agenda. So the webinar is composed by two blocks, which will be having a clinical case and then followed by a talk on some more content, followed by a discussion where also individual attendees of this call can also ask questions via the chat box, and which will be discussed with our experts, which will be introduced briefly to you. The topic of the first component of the webinar will be hs-CRP and secondary prevention, and the second component of the webinar will be on the part of hs-CRP and primary prevention, with additional focus on other biomarkers. In the end, we will have some closing remarks and take-home messages. So the IAS Inflammation Academy is a program by the International Atherosclerosis Academy aiming to identify and develop promising early career researchers and physicians who have the capacity to become next generation key opinion leaders in the field of inflammation in cardiovascular and also cardiometabolic disease. The program was initiated last year, and it's a very competitive global application process. 30 physician scientists from over 25 countries globally were selected. And on this slide, you can see our inaugural cohort. So this picture was taken last year at the ESC during our inaugural meeting in Madrid. So today's webinar was created and will be provided to you by our fellows group, which includes Nazim Askambayeva from Kazakhstan, Karin Ayub from Lebanon, Plamen Dunev from Bulgaria, Birken Kurt from Germany, Nikibah Mohammadnia from the Netherlands, myself, Alexander Peikert from Austria, and Kim Ngoc Tang from Vietnam. And at this point, it is my very distinct pleasure to introduce you to our faculty members who will be joining today's webinar call. So first, Professor Wolfgang Koenig from Munich. He's a professor of medicine and cardiology at the German Heart Center in Munich and the Technical University of Munich in Germany. He is a distinguished expert of inflammatory biomarkers, epidemiology, and also clinic-wise working as an interventional cardiologist. Then Dr. Libby, of course, is a world-renowned cardiovascular specialist from Boston at the Brigham and Women's Hospital. He holds a Mallinckrodt Professorship of Medicine at the Harvard Medical School. He is the past president of the IAS. He's also the program director of the Inflammation Academy. And Dr. Libby has pioneered research and completely transformed our understanding of vascular biology, providing that inflammation plays a primary role in atherosclerosis, and also its clinical complications, and also spared monumental translational milestones, notably helping to lead the landmark trials such as CANTOS, which were proof of concept for this hypothesis. Following the introduction of our speakers, I want to quickly provide some content on the importance of the topic of today's call. Given the increasing recognition of inflammation as a central driver of cardiovascular and also cardiometabolic disease, there are increasingly cardiac societies such as the ACC recognizing this importance by publishing scientific statements to support the implementation and of the value in risk prediction of residual inflammatory activity in clinical practice. And similarly, given the important role in pathophysiology, there's an increasing number of anti-inflammatory agents that may help to reduce the cardiovascular burden by directly targeting inflammation through distinct mechanisms that you can see on the slide. So to finish the introduction and to introduce the more interactive part of this webinar, we want to start with a question. Do you yourself consider inflammation when assessing your patient's cardiovascular risk? So this is a single choice question. You're supposed to see this poll on your screen, and you could then now vote. And after having voted, we will give everyone a couple of seconds. You could then see the results before moving on. Okay, so I will briefly introduce you to the results of the poll. So 17% consider inflammation when it comes to primary prevention, 9% when it comes to secondary prevention. Primary and secondary prevention are considered by 54%, so more than half of the attendance, and no, 6%, only in selected patients, 15%. Okay, so I will close this poll and we will now start with the first block of the webinar, which is on the topic of inflammatory biomarkers and secondary prevention of atherosclerotic cardiovascular disease. This part is provided by Karine Ayoub from St. Joseph University of Beirut in Lebanon. And Karine will start by presenting hs-CRP and secondary prevention. In addition, Nikki will follow her with some scientific background on the topic, which is followed by an interactive discussion. So Karine, feel free to move on. We're excited for your case.
Thank you, Alexander, for the introduction. So before we move into the evidence, I'd like to introduce a clinical case to illustrate the role of hs-CRP in secondary prevention and the concept of residual inflammatory risk. Let's start with a patient we might commonly encounter in clinic. Our patient is a 62-year-old male with an established cardiovascular disease. His medical history includes a controlled hypertension, prediabetes, and obesity, and an active smoking history of 64 pack year. Despite these risk factors, this patient is currently clinically stable. He reports no angina nor heart failure symptoms. He has good functional capacity, and he remains adherent to guideline-directed medical therapy. So at the first glance, this appears to be a stable patient whose cardiovascular risk is currently controlled. Now let's take a step back and review how he got there. 12 months ago, he presented with an NSTEMI and he underwent successful PCI. After that, he was started on intensive secondary prevention therapy, including a high-intensity statin and later ezetimibe. Over the subsequent year, he was clinically stable and asymptomatic. Now, looking at his biomarkers directly after the event, his LDL cholesterol level was 132 milligrams per deciliter, and his hs-CRP levels were 8.2 milligrams per liter. Of course, this elevated hs-CRP could be partly explained by the acute coronary event. However, what becomes interesting is how these biomarkers have evolved over time. As we can see, LDL cholesterol responded well to treatment, and particularly after the addition of ezetimibe on top of the high-intensity statin, and it reached the guidelines recommended prevention targets. On the other hand, as we can see, hs-CRP followed or decreased initially after the event and remained elevated throughout the follow-up period. So this case, therefore demonstrates two different biological trajectories. On one hand, LDL cholesterol falls rapidly following treatment initiation and remains well controlled, well below traditional secondary prevention targets. On the other hand, hs-CRP, as we can see on the screen, decreases initially, but it remains persistently above 2 milligrams per liter throughout the follow-up period. So this case highlights an increasingly important question in cardiovascular prevention. Despite optimal lipid management, inflammation persists. So can we consider that this patient is truly at low risk of recurrent cardiovascular event, or are we missing an important component of residual cardiovascular risk? While we go into the next section, I would like you to keep one question in mind. Should inflammatory biomarkers such as hs-CRP guide risk assessment and influence management in secondary prevention? To help us answer this question, it is now my pleasure to introduce my colleague, Dr. Nikki Mohammadnia, who will take us through the next section of today's webinar and present to us the evidence behind inflammatory biomarkers in secondary prevention and their clinical implication. As we move into this next section, we encourage you to submit any question you may have in the chat box throughout the presentation. We will be happy to address them during the discussion and the Q&A session with our experts, moderated by myself, and by my two colleagues, Dr. Nikki and Dr. Kim. Dr. Nikki, the floor is yours.
Thank you very much for the kind introduction, Dr. Ayub. So yeah, let's talk about inflammatory biomarkers in secondary prevention of hs-CVD. So before we can answer your questions, it may be good to go back to the concept of residual risk. So let's roughly estimate the risk of this patient after his MI. We can say, again, roughly, that the largest contributor initially was his LDL, a slightly increased BMI, hypertension was well controlled, and his prediabetes also contributes. However, we know from previous studies that despite optimal medical treatment, patients continue to have high risk. And that's the red part. So what is this red part and what does it consist of? I'm going to take you through this next analysis. Well, if we look at this analysis combining 3 large clinical trials in a high-risk and secondary prevention population, they measured LDL levels and hs-CRP and divided the levels per quartile. Note that these patients were on conventional statin therapy. If you look at this graph, on the y-axis you can find the hazard ratio, which is shown for the risk for cardiovascular death, based on the quartile the individual is in. All in reference to the first quartile, you're going to see the hazard ratio for each biomarker. Let's show you the LDL cholesterol levels first. You can see only in the top quartile, a significant hazard ratio was found for cardiovascular death in reference to quartile 1. And now let's look at hs-CRP. Not only are the hazard ratios higher, but this risk remains significant even in the lower quartiles, quartile 3 and quartile 2 in reference to quartile 1. And in this analysis, similar results were found for the MACE endpoint. So inflammation contributes to residual risk. And to give clinicians a guideline how to assess, interpret inflammation in cardiovascular disease, the scientific statement by the ACC was published last year. And I just picked out one of the recommendations, one of the most important ones, stating that we don't treat what we don't measure. You're not going to treat LDL if you do not know the level. If you're not going to measure hs-CRP, you're not going to consider inflammation in the cardiovascular risk prevention of your patient. So let's go back to the case. First let's look at the guideline. Years before this ACC scientific statement, in the 2024 guideline for the management of chronic coronary syndrome, measurement of hs-CRP got actually a class 2A recommendation on top of the standard lab that we already do. And now we're going back to the case. So if we use SMART2 to calculate or to estimate the 10-year cardiovascular risk of this patient, which is hs-CRP of 4.1 milligrams per liter, and just note this is an estimate, but to give a feeling on how much hs-CRP actually contributes, the 10-year cardiovascular risk would be around 14%, 14.3%. But what if he had a lower hs-CRP? What if this biomarker was lower? Well, let's say he had a hs-CRP of 0.5 milligrams per liter. It would have been around 10.6, which translates in a relative risk of a difference of 25% roughly. It's just an estimation, but just to give a feeling of how much it contributes. So the question remains, we measure it, but what should we do about it? Well, we have several options also mentioned in the ACC scientific statement. You can, of course, intensify lipid-lowering therapy, which is also anti-inflammatory. But there's also one inflammatory drug, low-dose colchicine, approved by the FDA for cardiovascular risk prevention. And if we look at the most recent analysis published in the European Heart Journal, it is associated with a significant reduction in MACE. And in the same guideline, as I previously mentioned, it received a class 2A recommendation for cardiovascular disease prevention in secondary prevention. So the patient, What if we treat our patient with colchicine? Again, it's an estimated risk reduction using SMART2, but just to give a feeling of what we may establish with colchicine. His risk was 14.3%, and now with colchicine, an estimated risk reduction would result into a 10.5% cardiovascular risk for over the course of 10 years. Roughly the same as when you would have had with his low CRP levels. This translates into a relative risk reduction of around 25% and absolute risk reduction of around 4%. So beyond hs-CRP and IL-6 is also the name of our webinar. So what's more to come? Well, as Alexander pointed out in the introduction, hs-CRP is the end product of the inflammatory cascade. But more upstream biomarkers in the inflammatory cascade may be more specific markers as they are active participants. And in this very recently published analysis of the Odyssey outcomes, which is a post-ACS population on statin therapy, IL-6, which is a more upstream biomarker in the inflammatory cascade, showed an additive predictive value for MACE and death on top of hs-CRP. So IL-6 may be a very interesting target, and actually, as you may know, large cardiovascular outcomes trials are now being conducted. Ziltivekimab, which is a monoclonal antibody to the ligand of the IL-6 receptor, showed in the rescue trial substantial hs-CRP reduction up to 92%. And current trials are shown here, of which use is a trial where the results are expected the soonest, hopefully later this year. So we have an exciting year ahead of us for anti-inflammatory therapy in cardiovascular disease. So back to you, Karine. Having reviewed the evidence, does this help you to treat your patient?
Absolutely, Nikki. Your presentation has clearly addressed the role of inflammatory biomarkers in secondary prevention, and it provided us with valuable guidance for managing patients like the one I presented. And to further explore how this evidence can be translated into everyday clinical practice, let me now invite our panel of experts to discuss the case and share with us their perspective. We are delighted to be joined by two leading experts in the field, introduced previously by my colleague, Professor Peter Libby and Professor Wolfgang Koenig. Thank you both for joining us and for sharing your expertise with today's audience. For the first, we will address some questions to you, and of course we can address the Q&A question that we have in the chat box. And meanwhile, we invite you, of course, to drop your questions in the chat box. Now that we have reviewed the evidence, let's come back to our patient. Professor Libby, I would address this question to you. If this patient walked into your clinic tomorrow, should you be concerned about his cardiovascular risk? And would you treat inflammation? If you would do so, how would you do it?
Yeah, great to be with you. I'm very concerned about this patient's cardiovascular risk, and I'm an avowed LDL hawk. I don't pay too much attention to the guidelines. I try and get the LDL down as far as reasonably achievable. And I certainly think that he would meet some of the criteria for the colchicine trial. So it would definitely be a shared decision-making discussion with him. One of the issues which I think has limited the uptake of colchicine is its renal clearance. So practitioners need to be cognizant that you have to decrease the dose or be careful with administering colchicine in those with chronic kidney disease, which is very common. In my inpatient population, I did a back of the envelope tally of what the estimated glomerular filtration rate was on inpatients in the cardiology service in my hospital, and it was 45. So that's one proviso. So I check the renal function and then have a shared decision-making conversation with the patient about colchicine. And of course, we have hope that we'll have anti-inflammatories that will be approved in the wake of some of the trials that you just outlined.
Thank you so much for your answer. Now we will move to our second question. So we will address this question to Professor Wolfgang. So Professor Wolfgang, what are your thoughts on the ideal patient for colchicine therapy? And should we use hs-CRP at this threshold while trials have not used it as an inclusion criterion?
Yeah, I think that the case that you presented is a nice case to illustrate the potential implications of anti-inflammatory therapy. The patient responded very nicely to statin treatment, but what really is worrisome is the long-term elevated C-reactive protein, as we have shown above for a year or more than a year. So he has a significant inflammatory burden. It's a little bit tricky. I mean, it basically, and I agree with what Peter Libby has said, it's a little bit tricky insofar as he has two significant risk factors that also foster inflammation. And he was a heavy smoker, or he is a heavy smoker, and has an excessive BMI of 31. So both components contribute to the overall inflammatory burden. That's a little bit tricky, but we have to keep that in mind and also work on that area. The second part, I forgot what your question was.
Yeah, for the second part, should we use hs-CRP at the threshold while trials
Yeah,
are not?
yeah. That's a problem, or that's an issue that we probably cannot completely solve. You're perfectly right. The scientific evidence is based on Colcott, and in the chronic state on Lodoco-2. And in both of these trials, the C-reactive protein has been measured three months, I believe, after the initiation. There's no baseline level, and still in both trials there was a positive response. So purely from a scientific point of view, you would say, okay, do it in these patients where you have a baseline C-reactive protein, and baseline C-reactive protein shows an increased inflammatory burden insofar as it is elevated. So I found from a clinical perspective nice to have a baseline because then you can see what you have achieved, see responders and non-responders that has, for example, nicely shown in the CANTOS. So there is some kind of distance between the scientific evidence and the practical clinical practicability.
And how would you? So when would you measure hs-CRP after an event? What would be the best timing? And would you also follow up your hs-CRP measurement? Would you measure your effect? Maybe for Professor Libby.
Yeah. So by 1 month after an acute coronary syndrome, the acute phase response has subsided. So I think 30 days is a reasonable time to regauge the baseline. And then we don't really have evidence for how to follow a CRP after instituting colchicine, for example. So I think we leave that to your clinical judgment. We don't have an established target either.
I have a question. The cutoff of hs-CRP, I don't know why we choose the 2 milligram or US. I see the cutoff hs-CRP, the 3 is the different.
Yeah. Well, 2 was chosen in an early meeting by our Center for Disease Control because it's near the median of the population in the US, and it's an easy number for clinicians to remember, 2. Okay. We do know that, for example, in Asian populations, the median CRP may be lower. So we may have to calibrate what we call our median based on the ethnicity.
And Peter, if I may add to that, you and others are certainly aware that the cutoff of 2 was very successful in identifying high-risk patients that went into the Jupiter, for example, and even more important, into CANTOS.
Exactly.
Sometimes we, I see there are the hs-CRP and CRP. Many country we don't have a hs-CRP. Maybe I can choose the CRP only for inflammation.
Are you alluding to the difference between hs-CRP and conventional CRP? Did I understand that correct?
Yes.
Okay. Well, what we see and all the literature goes in the same direction. What we see if it comes to cardiovascular and inflammation, the range below 5, in particular below 3, is very much important, and you can't cover that with the conventional C-reactive protein assays that have been around for many years. So I would suggest an hs-CRP is necessary to fully detect the importance or the inflammatory burden of the patient. If you take a conventional one, you may miss something.
Okay, so we have a little bit more than 1 minute of discussion left. Just to let you know, maybe we can do one more or one last questions before moving on with the next content block of the webinar.
So I will have one question for both of you, Professor Wolfgang and Professor Peter. Do you routinely measure hs-CRP in your patients or only in selected patients?
Peter, you want to go ahead?
I have a quaternary referral practice, and I am asked to evaluate cardiovascular risk in the patients who are usually referred to me. So I certainly will measure CRP in my referral practice. And when I'm precepting all comers with my fellows, I will use it selectively, certainly in primary prevention.
Yeah. My practice is about the same, and I'm having a high risk preventive cardiology outpatient clinics, and in those patients who do have a high risk or who are at high risk, I certainly will measure the C-reactive protein, as has been already mentioned, 4 weeks or 6 weeks after the acute event. I think that's an appropriate time point, and follow up that differs. In terms of primary prevention, I think the most convenient or the most appropriate time point would be that when you measure all other risk factors, in particular a complete lipid profile. That would be the ideal time to add C-reactive protein to your clinical lab profile.
And I will measure the lipoprotein little a in addition to CRP, and the only advanced lipid testing that I do is apolipoprotein B. So when I see a patient who's referred for risk evaluation, those are the panels that I will test.
I'm glad that you are doing it, because ApoB, there's so much literature coming out. It is really important. We have been discussing that for years, but now it has to go. We have to go a little bit further and introduce it into clinical practice. It's not measured in most of the patients, unfortunately.
So we want to thank our experts, our fellows, and all the attendants a lot for participating in this engaging discussion. And now we will move on with the second part of the webinar.
Now let us go 10 years back, early in the disease process before the first cardiovascular event. We now have a 52-year-old male presenting for routine cardiovascular risk assessment. He has no known cardiovascular disease, but he has several important risk factors. He has controlled hypertension, prediabetes, a body mass index of 26.5 kilograms per square meter, and an active smoking history of 40 years. Clinically, he is asymptomatic. He has no angina, no heart failure symptoms, and maintains a good functional capacity. This may appear to be a patient at only moderate cardiovascular risk, but his laboratory findings show an LDL cholesterol of 118 milligrams per deciliter, which is only mildly elevated. His lipoprotein small a is within normal range, and his kidney function is normal. Using contemporary risk assessment tools, his estimated 10 years cardiovascular risk is 6% by SCORE2 and 6.5% by PREVENT, placing him in the borderline risk category. So based on traditional risk factors alone, the decision to start statin therapy is not entirely straightforward. But to further refine his risk, we assess inflammation. His high sensitivity C-reactive protein is 4.2 milligrams per liter. And because hs-CRP can be affected by temporary inflammation, any conditions, it was repeated 3 weeks later. And importantly, it remains elevated at 3.9 milligrams per liter. There was no evidence of acute infection or any inflammatory disease. This is where the case becomes interesting. His LDL cholesterol is only moderately elevated. His lipoprotein small a is normal, and his risk calculators suggest only borderline risk. Yet his hs-CRP remains persistently elevated. So the question is, would you initiate statin therapy here, or would you just choose lifestyle modification alone? On the following slide, you would see that in this case, the answer would be to start statin therapy together with intensive lifestyle modification. This case highlights an important message that in primary prevention, hs-CRP can help identify hidden inflammatory risk and support early preventive intervention in patients whose cardiovascular risk may otherwise be underestimated. And this brings us to 3 important questions. How would you assess this patient's cardiovascular risk? And does persistent hs-CRP elevation change your perception of this patient's risk? And are we missing hidden cardiovascular risk before the first event? To help us explore these questions further, it is now my pleasure to introduce Dr. Berkan, who will take us through the evolving role of biomarkers in primary prevention of atherosclerotic cardiovascular disease. Dr. Berkan, over to you.
Nazim, thank you so much for the kind introduction and the great presentation of this very interesting case. And I'm very delighted to give you a little bit of background information before we start into our second Q&A round. When we look at the guideline recommendations of the last decade, we see that hs-CRP has been already picked up by several global guidelines, starting in 2018 with ACC/AHA guidelines mentioning hs-CRP as a risk-enhancing factor. We also had guidelines from Canada and China mentioning hs-CRP as a risk-enhancing factor or risk modifier. The ESC has picked up hs-CRP in 2021. And the Japanese guidelines in 2022. And just this year and last year, the ESC and the AHA have also included stronger context for hs-CRP measurements in individuals without known ASCVD, mentioning hs-CRP as a risk-enhancing factor. But when we look at the specific recommendations from last year's lipid update and this year's ACC lipid guidelines, we see that on the left side, hs-CRP is included when it's persistently elevated, so 2 milligrams per liter or higher. And also here in the ACC guidelines, we see hs-CRP included also with 2 milligrams per liter, in both cases combined with each individual score algorithm. So in Europe, we have the score 2, where it's additionally, where hs-CRP can be additionally considered. And in the American guidelines, we have the PREVENT algorithm. When we look at the already mentioned ACC scientific statement on inflammation and cardiovascular disease, in primary prevention, we have a granular risk stratification. So here we have risk strata of below 1 milligrams per liter, between 1 and 3, and above 3 milligrams per liter, where we stratify individuals in primary prevention. When we see levels of above 10 milligrams per liter, we should consider a possible acute phase response, for example, in the context of acute infections. When we look at the recent data backing up these findings, 3 large-scale cohorts, one of them were published by Paul Ritke in 2024 in the New England Journal of Medicine from the Women's Health Study, where we were able to see that quintiles of hs-CRP levels above 30 years in women free of known ASCVD were highly predictive of cardiovascular outcomes. These findings were also presented in a Dutch cohort and published last year, also showing a strong association of cardiovascular risk. And also, these findings were shown in the UK Biobank, where the just mentioned cutoffs of 1, 1 to 3, and above 3 were validated in a UK cohort of the general population. But what if we look beyond hs-CRP? We have spoken about IL-6 as a key and biologically relevant molecule in this. And we have plenty of studies shown in this meta-analysis here showing a strong association of IL-6 with cardiovascular risk. But what about the clinical implementation? IL-6 has many burdens that it faces when you try to implement IL-6 in clinical routine assessment. So there are clinical burdens, but also biological variability, analytical burdens. Of course, logistically, it's more complicated to measure IL-6 in comparison to hs-CRP, which is widely established in global laboratories. And also there are economical aspects to be considered. But when we look even beyond IL-6 as a biomarker, there are even more novel approaches which offer a more granular risk stratification, also in primary prevention. We have, for example, ideas of metabolomics or polygenic risk scores that can enhance, for example, as shown by these data, SCORE2-based risk prediction in primary prevention. When we look deeper into polygenic risk scores, we have a just recently published paper in the New England Journal by Professor Schunkert from Munich, showing the huge value that potentially lay in the interesting concept of polygenic risk scores, but also with a potential therapeutic strategy addressing risk, which is expressed by polygenic risk scores. But how do we address residual risk that is established in individuals in primary prevention? When we have a look at the ACC inflammation statement, which picked up a figure that has been known for quite a while now, we know that many factors contribute to development of inflammation, also in primary prevention. But when we look at specific recommendations, lifestyle interventions should always be considered in the first stance. When we look specifically, of course, there are recommendations regarding anti-inflammatory patterns in diet, specifically talking about Mediterranean diet or DASH diet. Also, of course, physical activity plays an important role. We talked about quitting of smoking, so smoking cessation, and maintaining a healthy weight. But what if we still have elevated residual inflammatory risk even after this? We have seen the Jupiter data in 2008 that has shown in primary prevention, if we reduce hs-CRP independently of LDL cholesterol, a finding of elevated hs-CRP levels, which is recommended in the ACC inflammation statement, should lead to a consideration or even initiation of either intensification of statin therapy or initiation of statin therapy. And this could be independent of LDL cholesterol. So now I'm happy to give the word back to Nazim. And Nazim, what do you think? How should we continue with these cases in primary prevention?
Thank you, Dr. Borkan, for this excellent overview and for helping us better understand the role of inflammatory biomarkers in primary prevention of cardiovascular disease. Well, this now brings us to the discussion and the Q&A session. Joining this discussion today are Dr. Borkan, Dr. Kim, and myself, together with our distinguished expert panel, Professor Peter Libby and Professor Wolfgang Koenig. Thank you both for being here with us today. And before we begin, I would like to remind our audience that you're very welcome to submit your questions in the chat box at any time throughout the discussion. And Dr. Kim will be moderating the chat and collecting your questions, and we will do our best to address as many of them as possible. And while we wait for questions to come in, we can start, right? So, Professor Libby, perhaps I may begin with you. I have here one question. From a mechanistic perspective, what does an elevated hs-CRP actually tell us in primary prevention? Is it merely a downstream signal of systematic inflammation, or does it identify a biological distinct atherosclerotic phenotype?
So first point is that our best information is that C-reactive protein is an excellent biomarker, but it is not causal. It is a reporter of the pathway which we've talked about, of interleukin-1 beta to IL-6. The second point is it's been said that C-reactive protein is nonspecific, and it reports on all kinds of inflammation. And indeed, I think that's why it works, because it reports on inflammation which can feed back on the atherosclerotic plaque, whether it's from a diabetic ulcer or from gingival disease or from the microbiome or from bronchitis. So wherever there is inflammation, it's going to feed back on the plaque to activate it. And C-reactive protein reports on all of those different types of inflammation. And I think that's one of the reasons that it's useful. So when I'm confronted with people who say C-reactive protein is nonspecific, I say that's why it works.
I see, right. Thank you, Professor Libby. That's a very important perspective. Maybe Dr. Burkan, you can take us through the next question.
Thank you, Nazim, and thank you, Dr. Libby. So my next question would be for you, Professor Koenig. So you've worked on hs-CRP in population cohorts for decades now, but still the question remains, why do you think hs-CRP has remained underused in routine primary prevention? Since we have established epidemiological evidence, and if this evidence is so consistent, what is missing for routine implementation? Do we need better trials? Do we need better guidelines, algorithms, or do we simply need to work on clinical acceptance?
Yeah, I think that's the crucial question. And as we have already discussed, it's C-reactive protein is only infrequently measured, in particular in primary prevention. And I think the reasons for that is a mix of some of the points you mentioned already. I think in Germany, for example, it's lack of clinicians' acceptance because they are so very much familiar with C-reactive protein as part of the infectious disease workup, etc. So it's difficult for them to link it to inflammation associated with atherosclerosis. In terms of clinical trials, I think compared to the secondary prevention, there's still some room for improvement. You have mentioned the Jupiter study, which has nicely shown that reducing C-reactive protein in this primary prevention population has a tremendous benefit. Don't forget this, even the cardiovascular or total mortality was reduced in Jupiter. With regard to guidelines and algorithm, there's also some improvement possible in my opinion. Guidelines do say measure it in the CCS guidelines, for example, say measure it once, but they don't. The guidelines are not specific enough to provide you with a detailed response when exactly you should measure it. And also the algorithm is relatively vague, so to say. I think on these two issues, there could be, I would like to see improvement.
So I would like to follow up maybe exactly on what you said, Professor Koenig, maybe with a follow-up question to you, Dr. Libby. Because we don't have clear guidelines yet as on how to measure hs-CRP and in which circumstances to measure CRP, can we actually trust one measurement of hs-CRP? What's your view on this? Or do we need to do sequential testing? Can we trust one singular measurement?
Yeah, absolutely. So another criticism that's been lodged against CRP is that it's variable. And in the placebo group of Jupiter, we looked at the stability of CRP, and it is just as stable as systolic blood pressure and as total cholesterol. So it is, however, increased if there's an intercurrent illness. So if someone walks into your office and has a C-reactive protein of 7 or 11, I will ask, did you just have a cold or the flu? And that's when you can wait for 2 weeks and measure again. And also, if you have someone with ambient increase in C-reactive protein, you can ask yourself if there's an underlying inflammatory disease such as rheumatoid arthritis that will give you a basal elevation in C-reactive protein. But a single measurement of CRP correlates with risk. You showed this slides from the Women's Health Study and from the Northwick Park Study and from UK Biobank, and those were based on a single measurement. So it's like systolic blood pressure. We knew the insurance companies knew in the 1920s that a single measurement of blood pressure was a prognostic for death. So same thing with CRP.
I think it's still a myth saying that C-reactive protein does not really work because it's too variable. This is not the case, as has been shown in the studies that you mentioned, but also in other ones. So it's not worse than LDL cholesterol in terms of the variability. Maybe it's even better. And if you have one measurement that's in the normal range, it's fine. If it's elevated, obviously you have to look what you just mentioned for a secondary cause, and unless you have not excluded that, you have to do a second measurement.
I see we already have some excellent questions coming through in the chat, so I would like to read one of them. How would it's addressed to both professors? I don't mean it. How would you approach cardiovascular risk management in a patient with an estimated score 2 risk of 3%, but with a chronic autoimmune disease and persistent low-grade inflammation? hs-CRP is more than 3 milligrams per liter.
Well, let me take a shot at that. The field of cardiorheumatology is burgeoning, and we know that patients with all kinds of rheumatologic disorders are at elevated cardiovascular risk. It's underestimated, undertreated, and I would be very aggressive with treating risk factors in people with these chronic inflammatory rheumatologic diseases.
Thank you, Professor Libby. Those are excellent points. So we have to be more aggressive with the management, right?
Yes.
Maybe I can follow up with another question from a chat, picking up something we have discussed before regarding the synergistic prognostic effects of Lp(a), hs-CRP, and LDL cholesterol. Professor Koenig, do you think we need general screening of these biomarkers in the population, or should we integrate maybe sequential testing of these biomarkers?
I mean, as you know, guidelines have already suggested to have the Lp(a) measured at least once in a lifetime. I think the opinion on that varies a little bit because more and more we learn that there are still some variation based on menopause issues, based on large consuming diseases, etc., etc. So maybe your opinion changes. In terms of C-reactive protein, I would measure it at the same occasions that I have mentioned before. In primary prevention, when I do the whole lipid profile, and Peter has added the Lp(a) and ApoB, which is quite correct. And in terms of secondary prevention after myocardial infarction, and then maybe at consecutive visits if there are some minor symptoms, or if you are not sure whether or not you are still on track with regard to the anti-inflammatory therapy. So these are the main situations where I would primarily go for C-reactive protein measurement.
Thank you so much for your input, Professor Koenig, Professor Libby. We will now have to continue with our webinar, and I'm happy to give the word back to Alex.
Perfect. Thank you, Berkan, and thank you to all our experts and discussants again. So following this webinar, including our cases, presentations on scientific content, as well as the engaging discussions, we want now to repeatedly ask the same question that we asked you in the beginning. So do you consider inflammation when assessing your patient's cardiovascular risk? So it's the same question. Now, having heard our webinar, would you respond to this question differently or not? So we are excited to see the poll's results. Here we have the results. So it seems like now we have 9% that would consider inflammation for primary prevention, 7% for secondary, but now 78% for primary and secondary, coming from 54. So that's a huge increase. So I'm happy that we could provide some information here to help you for your clinical practice. Okay, so now following this poll, it is time to summarize our webinar's content. So, and therefore I want to pass it for the first point to my colleague Plamen. So Plamen, please, you can start with the first bullet point.
Thank you, Alexander. So we can conclude that it's really now very well known that inflammation is a causal, measurable, and actionable cardiovascular risk factor. I think we have no doubts now.
So, and second, hs-CRP, when it comes to biomarkers, hs-CRP is the biomarker of choice right now for residual inflammatory risk assessment.
And inflammatory risk should be considered alongside traditional risk factors in our routine daily practice.
And another important point is that residual inflammatory risk persists in many, many patients, even if they are on optimal comorbidity management. So you should always consider residual inflammatory risk.
Now we have emerging therapies, including interleukin-6 directed interventions, representing a promising next frontier in cardiovascular prevention.
And as a highlight, we will now ask our experts, Professor Libby and Professor Koenig, for their key takeaways, for their take-home message. Please, Dr. Libby, what are the key takeaways regarding inflammatory biomarkers, how to use them?
I'd like to put this in perspective, is that I've been working on inflammation in atherosclerosis from a very basic laboratory level, starting really almost 50 years ago. And to see it now advance to the point where we're having a whole morning seminar about its clinical application is enormously gratifying. And what's really exciting is that we're on the threshold of an era where we're going to have not just colchicine, but we're going to have a variety of different anti-inflammatory interventions that we'll be able to deploy to address the residual inflammatory risk. And it's a very exciting time because I think we have a bunch of young, incredibly smart and motivated individuals in the Inflammation Academy. And they're going to carry this torch forward with many more tools that will allow us to help our patients with inflammatory risk.
Professor Koenig, we will move on and ask you for your advice. So based on your expertise, what would be your take-home messages?
Actually, I have three points to mention here. Although it seems that we have been fairly effective and successful by increasing the number of those who feel that C-reactive protein needs to be measured in various situations, we saw initially a 54% of our attendees that would go for that, and now it's 78%. I still feel when I'm looking around and talking to my colleagues, we have to continuously work on the increased awareness of inflammation. This is a concept that has to be brought to our colleagues, and I like the term dual target because we have to consider both. Obviously, the central focus is on lipids, but even likewise of importance is inflammation. So both come together. It's not an either or. It's both have to be considered, and we have means to do that. The second point is we need to stimulate our colleagues to measure the C-reactive protein in various situations, namely secondary prevention and primary prevention. If they don't get any experience with that, they cannot draw any conclusions. And finally, they should think of anti-inflammatory therapy. And with colchicine, we have a well-tested anti-inflammatory drug on board. And hopefully in the near future, this will be complemented by other anti-inflammatory drugs, for example, IL-6 inhibitors. This would be my 3 main points to convey to the attendees.
These words are a very good way to close the seminar, but as I introduced to you before, we have an upcoming event that we want to advertise, and Flamen will give you some insights.
Of course. And finally, a quick invitation to every one of us who is passionate about the future of cardiometabolic health. Please mark your calendars for October 2027, when leading global experts will gather in Chile for the International Symposium of Atherosclerosis. This is the perfect opportunity to exchange experience and in the prevention of cardiovascular disease, exactly the topic we are discussing today. Visit esa2027.org to explore the program and participation opportunities. And now, please take a moment to scan the QR code on your screen to vote and rate your today's webinar content. A big thank to all of you and all our attendees and entire audience for joining us today and for your active participation. We look forward to seeing you as soon as possible again in the near future. Thank you and goodbye.